Our next session examines the complex challenges faced by youth in the child welfare system who lack stable placements and present with significant mental health needs, often intersecting with the juvenile justice and adult criminal justice systems. Luanne Southern and Sierra Fischer with the Texas Department of Family and Protective Services and Matt Smith with the Texas Juvenile Justice Department will highlight systemic factors, current initiatives, and collaborative approaches to improve outcomes for these youth. I do want to say a few of my own words. We are very grateful to have Ms. Southern. Her setting currently is in Harris County. Yes?
I'm actually with the state DFPS.
But you came from Harris County.
No.
No? Okay. So I thought that your previous experience was in Harris County where you had your, prior to being in Travis County with the state. What I do know is that you serve on the Permanent Commission on Children and Families and have really benefited our youth. What I want to say about both of our Ms. Southern and Ms. Fischer is that they're using their smart brain to give us actionable insights, not just observing the problem after data collection. They are actually giving us deliverables available to us in the trenches, changing the lives of kids. And so I apologize for not knowing you were not in Harris County. Matt Smith is also the OG of juvenile and trauma-informed therapy. In the juvenile justice system, he and his chief, Scott Matthew, transformed juvenile justice in Williamson County, which we all copy in the sincerest form of flattery. And now we have Matt Smith with TJJD, which we're very grateful. All three of you, welcome and thank you.
Thank you.
Good afternoon. So I'm going to kick it off with a data overview of this population, and then I'm going to hand it over to Matt to talk about the juvenile justice population, and then Luanne for the child welfare lens. So I'll start by giving a landscape of the child welfare and juvenile justice and the families and youth our agencies both serve. So we do a data exchange with TJJD, and we found that 16% of our youth in TJJD were actually in substitute care. So they were in out-of-home placement at some point in their lives. So this is a 2-year population, we're looking at about 329 youth. And research has shown that these youth have much negative outcomes for this dual status population, and the families have more stressors and requirements by working with both agencies. So we think that cross-system collaboration is vital for this particular population, and we also recognize that they have complex issues. And what we're seeing nationally, and then also specifically in Texas, is that our juvenile justice and child welfare systems are supporting these complex youth, and we're not necessarily equipped, at least traditionally, to serve this population. So a recent study of 125 health and human service agencies has found that the most complex youth are coming to juvenile justice and CPS. And so today we want to focus on one population, and this is one specific population, and this is the families that are coming to our DFPS with a refusal to assume parental responsibility. So we call this RAPR for short. And I purposefully chose a maze as the background here to demonstrate that these families have been, trying to navigate the complex system of mental health and behavioral health for their families. And I think they're coming up against maybe a false end, right? And they're coming to the department for lack of mental health or IDD services, for lack of medical services, or solely to obtain mental health services. And so I want to focus on this population because I think that we need cross-system collaboration, community supports to be able to help serve this group of families and children. So they're coming to DFPS through a call to the hotline, and 22% of these wrapper allegations are being reported by law enforcement. Now, all other allegations, law enforcement is some of the most common reporters, so all other allegations are about in line with that, so 23% of all other allegations come from law enforcement. But we're also seeing a higher rate of these wrapper allegations come from parents themselves calling for help or support. So 13% of the calls come from parents. And then I want to make a note on this parole and probation officer. So typically 1% of allegations come from parole or probation, but in this instance, we're seeing 7%. So the juvenile justice system is really also working with these families. So what does this look like in a numbers perspective? So this is about 2,000, just over 2,000 investigations per year for wrapper specifically. And of those investigations, we see around 400, just over 400 youth come into our care, in collaboration with the courts for this removal reason of wrapper. So this removal is about 5% of all of our removals, and compared to what we're seeing nationally, other states, the range of custody relinquishment is around 1 to 18%, depending on the state. So Texas is kind of in the middle there with 5%, but Texas is big, so 5% is a good amount. Around over 400 kids in the last couple of years, but as we had a higher rate of removals in prior years, that number was even larger. And as I'll explain, children are staying in our care longer, which compounds. Their needs are compounding within our system, and so we're struggling to meet those needs for those particular children. So this particular population, these children have characteristics that are distinct from other children in our care. So they're teenagers. Their median age of removal is 13 compared to our typical age of removal, which is 5. We know they have emotional and/or mental health needs. Our best estimates at this point are around 80% of them have these characteristics. We know that they require higher specialized levels of care, so around 50% of them require our highest levels of care at DFPS. And we're also challenged to find suitable care. So we have a particular population of children without placement that are staying in hotels, and we're struggling to find care. And this particular group, 35% of them actually had a wrapper removal and came into our care for a wrapper. And I didn't include it in this slide, but because it seems so obvious, but also they have juvenile justice involvement. We don't have an exact metric, but they are coming to our care with juvenile justice involvement. And so just to give a comparison of national trends, in Florida and Kentucky, they were able to actually connect the child welfare system data to Medicaid data. And for this custody relinquishment population, they found 98% of them had been diagnosed with behavioral health condition in the year after entering foster care, and 1 in 5 were diagnosed with both a behavioral health condition and a disability. So obviously very high needs. And so I think another thing that's important to keep in mind is that nearly all of these children, when they have the wrapper removal, they were previously known to DFPS. So 90% of them had an investigation in their past. 50% had conservatorship, so that means 50% of these children actually had been in your courts. 15% had family-based safety services. So I think this showcases the opportunity for diversion. We are working with these families, and they are coming to, we know about them, we just need to work with them differently or offer them more resources. So I will pass it off to Matt in a second, but the key takeaways from the data, I think, demonstrates that many families with youth with complex needs are turning to juvenile justice and child welfare for support. We know that parents and parole and probation officers have high rates of reporting these wrapper youth, and it makes up a small number of our cases, but the children that have these have high and specific needs. So we really recognize the need for a cross-system and community collaboration to support these youth and families.
All right, thank you, Sierra. So wanted to just briefly introduce myself. My name is Matt Smith. I'm the Director of Statewide Youth Services Continuum at the Texas Juvenile Justice Department, TJJD. I've been with TJJD since April, and this is a relatively new role for TJJD that's really focused on a new team I'm going to talk about a little bit later in the presentation, designed to support counties and regions in Texas, juvenile probation departments and their regions, to assist with these youth with complex needs that need multi-system involvement and really need a different pathway in order to not penetrate deeper into the juvenile justice system. And so I've learned a lot since April 1st and been out across the state. But I'm going to talk a little bit, starting off here today, about a case study. And this case study came from my career at Williamson County Juvenile Services. I retired from there last March, was assistant chief for the last 14 years there, but worked for 23 years as a mental health professional in the juvenile justice system there. So this is, I've changed a little bit of the specifics of this data just to protect this individual, but it's a very similar case to what we saw come through. This was about a 2-year-old case. And so I want to just kind of talk through what these cases look like when they come into a juvenile detention center. So we had a case while I was in Williamson County that was a young lady who came in and was charged with assault public servant. She was not from Williamson County. She actually had moved to Williamson County in CPS conservatorship as a child without placement, so there was no place for her at that time, and she was living with her caseworker in a hotel. And while she was in that hotel, she was a survivor of child sex trafficking, and she was attempting to go back to that lifestyle. And so she attempted to leave the hotel room. Her caseworker was trying to stop her. She pulled her caseworker's hair and ran off and was later found by police. And so she was charged for pulling the hair with assault public servant. She was brought to our detention center, and when she got there, she was assessed, and she was a significant harm to herself, a really high acuity mental health case. And so unfortunately, the judge was not comfortable releasing her back to a hotel room, and so she ended up spending the next 6 months in our juvenile detention center. For pulling somebody's hair. So that would have been a type of case without the other factors involved that would have immediately been administratively released to a caregiver. But because of her involvement with DFPS, because of where she was residing, because of her high acuity with mental health, she spent that length of time in our juvenile detention center. We worked really hard, had a real collaborative team, lots of mental health professionals and stakeholders trying to support her. But almost the entire time she was in the detention center, she was on high suicide watch, which is one-on-one suicide watch. Even under that watch, she made multiple attempts and tried to harm herself, so we were not able to remove her from watch. She spent, we tried a bunch of different things through the court process to try to figure out what would be best in her case. We reached out to a lot of private psychiatric hospitals. Unfortunately, she'd been to most of them. And so she had been to 21 different acute care psychiatric stays at behavioral health hospitals. And the local hospitals and the hospitals in the region that we reached out to said she can't come back here. So she's too acute, and so she's on a list that we have that says do not admit. So then we reached out and we tried through the local mental health authority to get her assessed for the state hospital, and she obviously was assessed as in need of state hospitalization. But there were no beds available. And so she waited that 6 months in our detention center and eventually was able to be released to a state hospital bed. So you can look at this case. The last piece of it is the court and the prosecutor's office ended up non-suiting the case, so she was not charged. She was not adjudicated for her offense. You could say that's a success in that she didn't penetrate deeper in the juvenile justice system. But in looking at this case, we realized just how traumatic this was for her, and still she's just bouncing around. So I don't know the outcome of where she is now, but I know she's no longer at the state hospital, and I know that she has reoffended. So raise your hand if you work in this system, work in this world, and you've had a similar case in your jurisdiction. So absolutely. So these are not 1 in a million cases. These cases are becoming more frequent, and they're really challenging. And so I will say Williamson County is a resource-rich county. Lots of behavioral health services, wonderful local mental health authority, great juvenile judge, strong juvenile department, and we still could not find the right option for this kid. So that tells us that these are the kind of cases that we really got to work collaboratively across state agencies to do a better job with. And so that's what I want to talk a little bit about today. These are really, really tough cases. But I want to talk a little bit about some of the progress that we're making, have this be a little more hopeful. We've got a long way to go, but what I can share with you is that state agency leadership, DFPS, HHSC, TJJD, are really coming together to try to find some common solutions for all kids, because this is a kid that was touching every single system, and so many of our kids have had prior CPS involvement before they come to juvenile. They either have been or need to be in the mental health system, and they're all in school. So we've got to find a way that all our state agencies can come together to support these kids. We've been asked as state agencies, and I was in a meeting yesterday with some state agency leadership where we started reviewing collectively what's our wish list, what's our top 5, top 10 wish list, things that would really move the needle for kids. And so I'm not going to go through all 10, but I want to go through the top 5 of what we talked about today. And these are the TJJD wish list items. So these are the things we believe if we had in place, if we were able to make these things happen, then we could really help the kind of kids that we're talking about here. We could really move the needle, keep kids shallower in the system, keep them out of state hospitals, and get them the treatment they need. So the first one is short-term crisis residential, and we've got Bluebonnet Trails leadership here, Mike Maples, Executive Director. A short-term crisis residential model does not exist in the state of Texas. So we do have currently some crisis respite units across the state that local mental health authorities are operating. Bluebonnet Trails in Round Rock has been working toward a short-term crisis residential model. So this is a little bit more secure than a crisis respite center, and it would be able to keep kids a little bit longer and keep kids that are a little more acute. And so credit to Bluebonnet for starting to take this on. They've got the building, they just need the staff, and they're going to try to kick this off. But this type of model would really help on the front end of the system where we've got kids that have acuity and have committed some lower level offenses that just need a short-term stay that's not in the juvenile justice system or in DFPS facilities. So the other need that we think is really necessary out there is the longer-term secure residential treatment model. So that really does not exist yet in Texas either. There are other states that have some of these kinds of models. But unfortunately, kids that require residential placement, the large majority of them, unless you have really good insurance or lots of money, they flow through DFPS and through juvenile probation and TJJD. So kids get residential treatment in our 2 systems, and we need that to happen not in our system, but be available out in the community. So that's our second wish list ask. The third is expanded youth state hospital beds. So the data I have is a little bit outdated. It's from 2024, but in 2024, we had 91 youth beds across the state available to youth. And so just as a comparative number, we had 5,718 juvenile justice beds across the state. And so those are different things, but it just shows the disparity in the mental health opportunities for kids that need that and our juvenile justice system. Substance use disorder, residential placement, we have lost a lot of funding here. Phoenix House was one of the primary providers for youth substance use treatment. They lost funding for their programs in Austin and Dallas. And so kids that have a substance use need where they can't be in the community, they really need a short-term residential stay, have no opportunity currently. There's very limited opportunities there. So we definitely need some more of that, because what happens now is those kids end up in the juvenile justice system and have to go to post-adjudication placement to be able to receive that kind of treatment. The last model is another model that is sort of developing in Texas, so we've got a couple of counties, both Harris County and Travis County are doing a really good job with these juvenile justice diversion centers, so really focused on assault family violence cases. In some jurisdictions, that's as many as 20% of offenses that come to juvenile departments. But how can we keep those kids out of the juvenile justice system, out of the CPS system? And so these diversion models provide short-term respite, a place for the kids to stay, while the family conflict can be shored up, providing services to the family and work on that mediation and reunification process. So along with that, we're looking at assessment center models. The state of Ohio has just funded through their state juvenile justice agency some assessment centers to counties. And these are sort of like the adult law enforcement drop-in center, where law enforcement can bring kids to be assessed, to triage into services like crisis respite, for example. And so that kid does not have to go to detention. So it's an alternative drop-off place, and we're looking at those kind of models across the state. So again, this will take some time, this will take some funding, but I do believe there's a lot of momentum with all of our agencies moving forward and trying to figure out what are the alternatives that would keep kids out of the deep ends of our system. So I want to share briefly TJJD, what we've been doing as a state agency. For the last 2 years, we've been mapping the juvenile justice continuum of care in partnership with Meadows Mental Health Policy Institute. And so we've been out across the state in our 7 regions looking at juvenile justice data together with the chiefs in that region, hearing from chiefs, especially these kids with behavioral health needs or kids that are CPS involved that we're trying to keep shallow in the system. What do we need? What's working? What's not working? What are we struggling with? And so loud and clear, what we hear across the state is that we are not integrating, we're not coordinating well with our regions and in our counties. So there are exceptions to this rule, but overall, we need CPS and the schools and the local mental health authorities and the juvenile departments and the community at large to have more coordinated effort, coordinated funding, regional funding, county funding, so that we can do a better job with these kids that are touching all systems. We're too siloed. We're all struggling with workforce, and that's getting a little bit better these days, but how do we make that better? And so in about the next couple of months, at least by early December, we'll have some reports coming out. We'll have a statewide report that's going to really have tons of cross-system data, schools, CPS, LMHA, workforce shortages with mental health, and then some recommendations to move forward as a state. And with each region, how can we help move this system coordination forward so we can do a better job for kids, keep them shallower in the juvenile justice system? And so, got one other piece I want to share here. At the same time these reports are coming out, TJJD is also modifying how we're going to be providing services, support to our county juvenile probation departments and our regions. And so the idea is we are bringing in, we're hiring right now for 7 regional staff. They're called Continuum of Care coordinators, who will be able to support not just the juvenile probation department in those regions, but will work on really proactively developing the continuum of care in the counties and regions so that we can do exactly what we're talking about and do a better job of cross-system collaboration for some of these youth. So we have selected so far some really incredible applicants in 6 out of our 7 regions. We're still hiring for the West region. And we've also selected a statewide manager of Continuum of Care. Her name is Allie Madison. She's a clinical social worker that works for the Texas Juvenile Justice Department. So we're real excited to bring this team on board and are looking forward to connecting with a lot of you in your counties and regions and seeing what we can do to help move the needle forward. And so with that, I just want to, looking out there, I know a lot of you have been working hard in the system for a long time. This is not where we want to be right now in Texas for kids, but I do see all of this work, the Judicial Commission on Mental Health, everything that each of these systems been doing, how we've been trying each session to get more and more resources for kids. I do believe that we're at a place where if we make a coordinated ask and really come together, we can do much better for kids. And so the case studies like this are really hard to look at. We still have lots of kids today that are in that exact same position. But I believe in our state, I believe in what we're doing, and I think we've got a lot of room for improvement coming up to do a better job for kids. Sure thing. We would ask that you come to the mic for the question. It's for the people online. They can't hear unless you're at a microphone.
Okay, hi.
Hi.
My name's Sierra. I'm with M.P.A. I'm a court clerk. My question is that you're talking about all the projects and resources that you guys are trying to implement, which is awesome. We definitely need more of them. My thing is though, what about boys and girls clubs, community facilities or whatever, so the kids can have somewhere to go? A lot of kids, the main thing for their mental and breakdowns and everything and being in the juvenile system is because of their family. Sometimes, as you know, half of these kids, they only eat when they go to school, or they only hang out or stay away from home because the home life is so bad. So in my experience and dealing with kids, I would like to see if there's any way that we can or you guys can implement those other facilities as well, to keep them off the streets, you know, so they're not continuing to stay in the facility. I mean, I hear about rehabilitation and whatnot, but I hate seeing the fact that they are in juvie and then end up being in, you know, adult detention centers later on. So I just wanted to know if that was something in the works.
Sure thing. I really appreciate that question because I don't think I've done a good job of capturing that here. So what I'm talking about today is more the deeper end needs that we're looking at to keep kids out of the deepest end of the system. But the continuum of care model and what we're focused on actually starts at exactly where you're at. So we're using the sequential intercept model as a framework, which starts with community. And so we'll be doing that as well. We're really trying to develop those. Our regional reports and the statewide report will address all of that. So what are community resources we can get kids plugged into? What do we do at initial contact with law enforcement? How do the schools interact with this early in the system? You know, what do we do when a kid first gets a referral to a juvenile department? How do we divert that case? When the when the court system gets the kid, are there diversion pathways there, all the way through what I was just talking about, these kids that sort of need some short-term placement. So absolutely, the more work we can do on the front end, which in the sequential intercept model are intercept 0 and 1, that's the best bang for a buck, and we're also focused on that. So really appreciate your comment.
In other words, we need it all, the formal supports and those other supports for families. I am with the Office of Behavioral Health Strategy at the Department of Family and Protective Services. Our office is a relatively new office inside the department that was created during the 88th legislative session, because there was a recognition that many of the children that are involved in Child Protective Services also have behavioral health needs. And Sierra did a beautiful job earlier of talking about the story behind some of the ways that children and families access our services because they are in need of behavioral health care. And one of the things that we like to say, and in meetings I've talked about this, that the Department of Family and Protective Services and Child Protective Service agencies across the country are designed to protect children and keep them safe. We have become a place, though, where families, where children come to access behavioral health care. And I'd like to say as well that our agency has access to the same behavioral health system that the rest of the state has access to. And so there is no real magic, behind a child entering our care to access services, because for all of us, I think we're all trying to access care from the same system of providers. And I think that the other thing for us, and I have a list here of some of the existing services that we use frequently and that are available to families in the state. Some of these services were specifically designed to support families so that they would not need to access the child welfare system in order to seek behavioral health care. And one of those is the Youth Empowerment Services Waiver, which I know many of you know as the YES waiver. It was designed specifically for that purpose, to provide supports to parents in their neighborhoods and communities. There's also the Residential Treatment Center Project, which is through Health and Human Services. That is also designed to provide residential treatment for families who are seeking more intensive services and care for their children. We have purchased psychiatric beds also through the Health and Human Services Commission to be able to use revenue to buy inpatient care for families who need that particular service. There is a Resilient Families initiative that is accessed. It is being provided through a place called CK Family Services, and it is funded through Health and Human Services again to try to keep families together and preserve families that are in situations where they are in desperate need of behavioral health care. Then, of course, Matt mentioned crisis respite. We do access children's crisis respite through the LMHA system across the state and have found those services to be extremely helpful for our children. I will also say, Matt did another fine job of talking about kind of what our wish list would be. I would also say that the youth mobile crisis teams have been extremely helpful. The ability to have 24/7 pediatric crisis response with that intensive follow-up. I know many families talk about they don't know what to do or where to go if a young person in their home is experiencing a mental health crisis. They don't necessarily want to call 911, but they don't know what to do. And so to have the youth mobile crisis teams has been a real asset for our state. And to have them available 24/7 and to provide that follow-up that families also need. So it's not just going in to help resolve and mitigate the crisis, but also to provide that follow-up to make sure they're linked with services and supports in their community is really, really helpful. I think the bottom line for us within our system, and also I think Matt could probably agree for the youth who are in juvenile justice, is what we need for children really is a safe and stable place for them to go to begin to heal from their trauma. And what we find, and Matt mentioned this earlier too, is with his case example, is that young people may go into a facility to begin to have treatment, but then because of their behavior, they are released. And then they begin another cycle of another place, and then they get released because of their behavior. And what we would really like to see is more of an understanding that the behavior is often a manifestation of the trauma that they have experienced. And so to be able to have a young person enter a place that is stable, where they can begin to get the treatment they need to process and heal from the trauma, would be really, I think, our ultimate goal, right? And so I always think about outcomes, like what do we really want to see? What do we want to have happen for children? Like what would be the outcome for us? And I think families who are so desperate also to find services, one of the things we hear a lot is parents do not know how to access care. They don't know where to go. They don't know who to call. They don't feel like they have a place to access, like where is a centralized place where they can go. And I know I've heard that a lot from parents all across the state who just don't know how to access care. And if they wait until the situation's in a crisis, they would prefer not to have it be a crisis situation. They would like to prefer to be able to access something before it gets to that point. But having access to an array of pediatric behavioral health services across all provider types, and the reason that I said across all provider types is I know when we were developing the state children's mental health strategic plan, one of the things we talked about that's so unique about working with children and young people is that the system of care for children is more than the public sector. It also includes the nonprofit sector, and at times it includes the private sector, because sometimes families do have third-party insurance, commercial insurance, and so they utilize a different set of providers. So we kind of have to look collectively at all of it. What all is available for families, regardless of whether they are on Medicaid, commercial insurance, or don't have resources, and that's really collectively our pediatric behavioral health system. And then to have treatment that's really tailored to address specific conditions. So what does research tell us is the best evidence-based practice, for example, to address depression or to address anxiety, and how can we have access to more of those services that are tailored to address those specific conditions? And then, as was mentioned previously, if we have young people with really high acuity, we want their needs to be addressed through coordinated efforts, not only amongst our systems, but also bringing in the pediatric primary care provider system. Because of a shortage of child and adolescent psychiatrists, many families see their pediatrician for their child's behavioral health conditions. So we need to bring those pediatricians in as well and talk about what can we do collectively to address those needs. And then I mentioned earlier that providers deliver care that really recognizes that some behavioral symptoms might be manifestations of trauma. So that children don't just automatically get discharged because of behavior, but that they have a provider that really recognizes what is causing this behavior to happen. It's that old saying that we've heard over the years of what happened to you, as opposed to what's wrong with you, and being able to really think about that. And again, that crisis responses is available 24 hours a day, 7 days a week. And then I'll end with the ultimate one, which is that Our children and young people who have behavioral health needs experience lifelong familial permanency. In other words, children stay in families. Families stay together. And that can be an adoptive family, a kinship family, a foster family, or a biological family. But that children belong with families, that's really important. And now it's time for questions.
Sorry. I just want the people at home to hear as well. My question is to Ms. Southern and Ms. Fischer. How much training and education do you all give from your point of view on the words that are used to describe these youth in their paperwork, their evaluations that you're saddled with, that you receive from their schools, that say things like the previous speakers were talking about, like the conduct disorder and the ODD that hasn't ever been questioned, and then they come to your care and no one ever parses those pieces of information to say, that doesn't even apply to this youth. Could you speak to that issue?
That's such a good question. What I can say is that, you know, oftentimes there are words that are used, right? And when people look at the sheet of paper, they might have an assumption about a young person based on what they're reading. What we try to do, and we have staffings that happen. We bring in Health and Human Services. We bring in sometimes Juvenile Justice Department. We bring in a lot of different community folks and have, we call them like staffings for a lot of these children who have these high acuity needs. And when we talk about those young people, we talk about them as people. Because oftentimes they are in a place, like they might be in a treatment facility or another place. They might be in juvenile probation. And so the folks that are working with them can see who they are as people. And we really try as much as we can to really just talk about, this is Johnny. This is what we know about Johnny. This is how he is behaving now. Yes, he has this history. Here's what we see as his strengths. Here's what his needs are. And we try our best to do that. To really make it more that we are all human beings, you know, and we have to think about these young people as young people. And they have had, many of them, very difficult histories and pasts, but we try to talk about them in ways that we can see their strengths.
Hi, I'm Cheryl Mabry. I'm the judge of the Child Protection Court of the Hill Country. I preside over 7 Hill Country counties and have a child welfare docket. So thank y'all. I have just 2 comments, and then I have to read because it's kind of long that I wrote. I really wish that the DFPS would urge y'all's caseworkers to work closely with the LMHA staff to know what local services are available, because I know out in rural Texas, nobody knows anything. And another thing, I know this is way beyond our pay grade here, but if all the regions would be the same, like CPS, the TJJD, the LMHA, where we're all together and we don't have to overlap, that would help tremendously. But like I said, that's over our pay grade. But I saw your map and I'm like, wow, that's really weird counties there. So in the Region 1. I want to know with I have to read it, I'm sorry. With the legislative changes when the removal statutes were changed beginning in 2021, are the rapid number of children the same? DFPS just is not able to remove them because the statutes have changed. And so then are more children being referred to FPSS? Does it make myself clear?
Yeah, I think the statutory change did change the number of removals and what types of removals we can have. So I can see that the number went down. It still represents, wrapper still represents about 5%, but the removal, the statute did change, which changes which type of cases we remove.
So then what is DFPS doing to work with these the children that are wrappers, but they're not really removed because they're just working under F.P.S. services. Because I know in rural Texas, F.P.S. services are very, very limited with, maybe 1 or 2 or 0 providers.
I'm not sure I can speak to that from a data perspective, but we could try to get more information on that.
Okay, well, once again, that's something else I urge y'all to work more with the FBSS out in the rural counties, especially with these children we're talking about. Thank you.
Well, and I want to say I'm glad you brought up the LMHA caseworker partnership, because we have been working actually on regularly getting information out to our caseworkers across the regions about resources, new resources as they come available, and connections with their LMHAs and other providers across the state. We worked on a map actually to try to help our caseworkers kind of see what's out there in their geographical area of responsibility, because we do think, all the action happens at the local level. And so being able to make those connections and knowing, who to call and how to access care. For example, I mentioned the youth crisis outreach teams earlier. There are certain parts of the state that have those. We want to make sure the caseworkers that are in those areas of the state know they're there. Same with the crisis respite, a lot of the different resources, so that we can keep them updated regularly.
And if y'all could make those available to the prosecutors, to CASAs, to the juvenile probation departments, because we all work together, and right hand doesn't always know what left hand's doing. Okay, thank you.
A quick follow-up to the question around case notes and language. So I do a lot of work around the overrepresentation of Black and brown kids in the systems that y'all are working with. So when thinking about language, is there any sort of training and things that's being done around cultural competency? I'm thinking particularly when we talk about girls or boys, right, presenting, are they hypersexualized, and how that follows them, and the words aggression with placements and making it harder. So one, is that being done? Are there resources available? And if not, are you all open to seeing that into a fruition?
Could we ask for that data?
I can tell you. I can tell you that. Are you asking specifically for we did just have a legislatively mandated report come out in the last week about disproportionalities and disparities. So that is data that we do have available. Good. I'm not sure I can speak to cultural competency training. That's outside my wheelhouse, but
I can say with TJJD it's required, and it's also, there's some pieces of PREA training that includes that. But having said that, we do need additional training in that. I think there's opportunity to do a better job with that.
Thank you.
Great question. Worth the few seconds or minutes. Thank you so much to this panel. I do want to give a round of applause. It's a tough area. We all see it. We all see that there's a huge problem and a disconnect between the systems. So hat is off to both of these systems working together. And let's get TEA and LMHAs to the table as well. Thank you so much to each of you, Ms. Southern, Ms. Fisher, and Mr. Smith. We all appreciate you so much.